Assalamu alaikum. This is Dr. Naeem. I'm consultant cardiac electrophysiologist from Saudi Heart Rhythm Society. Thanks for joining us for this webinar. We have two eminent electrophysiologists. They're a friend of mine. I like their talks, and hopefully they can share some ideas and technique with their expertise. So the seminar today, it's about advanced ablation technology. And we will talk in two different presentations. First one by a friend of mine, Dr. Ruben Casado. He's from the Free University of Brussels. He taught me first about the HD grid and how to use it in WBW. And we shared a couple of cases of WBW mapping by HD grid. So first, he will talk in the first presentation of experience of using the HD grid. Welcome, Prof. Ruben. Thanks for joining us.
Thank you.
And then we have the second presentation by well-known Dr. Ivo Rocca. So he's from University Hospital Clinic of Deep Barcelona, and he will share his value of MRI imaging and guiding VT ablation, which is very important for us as electrophysiologists in collaboration between imaging and electrical activities. So I think without further ado, let's start with Ruben Casado. I think if you can share your presentation, and he will talk about his experience using the HD grid catheter in complex ablation. And please, for the all audience, if you have any question, just go ahead in the Q&A button and then just tap your question, and I'm gonna read them to the presentation. All right, so let's start. Ruben, mic is yours.
Salam alaikum. Thank you, Dr. Naeem, for the introduction and the invitation. Dear colleagues, my name is Ruben Casado, and I'm very pleased to be here with you today and to be able to take part in this interesting event. I would like also to thank the Saudi Heart Rhythm Society and Abbott for their support to this educational initiative designed to provide a platform for the exchange of knowledge and introduction among healthcare professionals. Today, I'm going to talk to you about high-density grid mapping in different substrates, like accessory pathway, ventricular tachycardia, and atrial fibrillation. I would like also to start with one of our cases that we published 2 years ago in JACC-EP. It's about a woman of 53 years old who presented to our EP lab with an orthodromic supraventricular tachycardia in the context of a left lateral accessory pathway. What we did, we started a regular EP study, and we mapped with the high density grid catheter the activation during the tachycardia. And I would like to focus your attention how we place the catheter around the mitral annulus from left to the right, and also the unipolar activation during the tachycardia. I would like also to focus your attention also in the best unipolar, the best, as the electrophysiologists said, the best DVDT or the best QS. And you can see here that the best QS, the best unipolar electrogram, corresponds to D1. So from that point, we isolate these electrodes and we move to the next slide. You can see here that we start from the best unipolar, the best QS activation, and we can identify the trajectory of the activation of the accessory pathway of the supraventricular tachycardia. And we start from D1, D2, when you have a fusion of a ventricle and atrium. Then we move from D2, D3, and you can have a big ventricular electrogram and a smaller atrial electrogram. And the last one, the last trajectory through the atrium, you have D3, D4, when you can see the inverse activation, a smaller ventricular, a bigger atrium, and also a Kent potential. At that point, we speak with our technician and we tell them to tag this point. Please tag D3, D4 in the electroanatomical mapping. Afterwards, we only have to go there with our ablation catheter and make the application, and you will eliminate the accessory pathway with a single shot. As you can see, you can also identify that the trajectory of the accessory pathway is not in other direction. For example, from D1 to C1, because here you can see that you have a ventricular activation and an atrial activation that both are very split and is not the same that the previous one, that is D1, D2. If we take the oblique image, that is the D1, C2 electrogram, you can see that you have a shorter BA activation, but it is not as good as the original trajectory of the accessory pathway, that is D1, D2, D2, D3, and D3, D4. So as you can see, in complex supraventricular arrhythmias, high density grid has an added value, mostly because you can shorten the procedure time and you can identify the place of ablation very fast and doing much more procedures during your EP day lab. I would like also to show you another case. It's a VT ablation, ischemic VT. I don't want to insist because Dr. Ivo Roca is going to extensively describe more than me what I'm going to speak, but it's no more than an ischemic VT with a focal activation coming from the septum. And what is the important thing of this tracing is that we were able to map the ventricular tachycardia during the tachycardia with a high density grid. And you will see the quality of these tracings. Also, of course, we do with entrained mapping, but I would like only to show you the activation during the ventricular tachycardia. The same than previously, as you can see the quality of the mapping, we also have looked to the unipolar electrograms during the tachycardia, and the same that we did with the accessory pathway, we did also with the focal activation, the focal exit of this ventricular tachycardia. You can see the mid-diastolic potentials, and you can see here the electrogram activation of the unipolar electrodes. And if you analyze it locally, you will see that the best one is B3. The same that with the accessory pathway, we were able to isolate, with the help of our fellows and technicians, the spread of the mid-diastolic potentials in this setting. What we did at this point, we tell also our technician of Abbott, please tag all this region, mostly B3, and all the electrodes around. Again, we ablate these regions, we consolidate it, and the result was also very good. So as you can see, a few seconds are enough to map this complex substrate, and also they provide a lot of information for ablation, treatment, and improving your results. Another case that is mostly another ventricular tachycardia in the context of an anomaly, you will see that this is a patient around 29 years old who came to our lab to Brussels from another center. And as you can see, this is the scanner that we did to exclude ischemic ventricular tachycardia. You can see that there is an aneurysm at the level of the apex in the context of a malformation, of course. And in this context, we decided to perform the EP study to see the substrate. The basal electrocardiogram show an origin compatible with an extrasystole coming from the apex of the left ventricle, and that is because of the negative deflection QS in VESIS. And he presented also sustained ventricular tachycardia. Here is an example of not sustained, but during the ventricular protocol, we were able to induce the same clinical tachycardia that was very reproducible. So what we did, and I would like to show you this catheter. This case is to show you that you can use the catheter without any problem. You can push your catheter to map this structure because it's very important to identify the substrate and also the electrograms. And you can see that at the apex of the left ventricle, where we are there with a high density grid, there are no electrograms. And even the wall is not very thick, as you can see. It's only a few millimeters, but you can define easily and push without any problem. You will not perforate, and that is important point, safety of this tool. You can see that the scanner matched very well with what we did. And also you are able to identify the activity, minus 45 milliseconds, of course, we're at the level of the apex, concordant with the electrocardiogram. And also one important thing is that with the high density grid, you can pace, and the pace mapping was very good for the electrophysiologist. If you are close to 100%, you are at the region of interest. And here was close to 97. So what we did at that point is an important issue, because we realized that the wall at this region is less than 1 millimeter. So we decided that perhaps was not a good idea to perform an endocardial ablation at this point. We have already defined very well the substrate with the high density grid catheter. And at that point, we decided to go home, to speak with our cardiac surgeons and to do this procedure with them in the operating room. You can see that the apex of the ventricle collapsed, and that fits very well what we did during our EP study. So in this context, we decided with the surgeons to do an ablation and elimination of the aneurysm, and the patient after 2 years is asymptomatic with no recurrence of arrhythmia. I also would like to focus your attention in other substrate. That is what we are doing mostly here in Belgium and in Europe, that is atrial fibrillation ablation. More than 60% of our activity is AFib ablation. And I think that high density grid has an added value, because we are able to identify fast the gaps when there has been an ablation in the previous period. And this is an example that I would like you to see. We don't have a lot of time. I know that Dr. Naim has a lot of questions, but I would like to focus your attention in the right side, upper right side, and you can see this is a gap of the right superior pulmonary vein. You can see the quality of the electrograms and how fast we are able to map this region, and the quality of the electrograms. Easy identification of the gap, and in that point you can only tell your technician, again, please tag these points. I will go to ablate now, straightforward. And you will do it fast and good and without any problem, and you will reduce your procedure time, and you will improve your outcomes. I would like also to show you the electrograms. Here is a photo of that, and you can see how easy it is to map the fragmented potentials that are an image of the reconnection of a pulmonary vein. Again, here you can see it, how easily you can define it. So as a resume of this interesting meeting, I would like to, how can we justify the use of high density grid now in our hospitals? Because it's true that it's a new technology. It's true that it's a bit more expensive than previous catheters, or not. But well, it's clear that, that we will reduce time of procedures, that we are able to a better understanding of the substrate, that I'm sure also that we will improve outcomes. Also, I would like to call the attention of Abbott. They have to invest more in research, because we will have to develop with them algorithms to a better identification of the substrate, and also that should be based in impedance. For example, to know when you are in contact with the cardiac tissue or not. Finally, all this information will be translated in cost. We will reduce cost because the procedure will be shorter, we will have better outcomes, and we will probably speak in the future, near future, about the substitution of different technologies or different mapping catheters. So I think that this tool is very interesting for the future, that there are a lot of things to develop. And I think that the collaboration between physicians, between different centers to publish our experience is an important solution also. And I would like to invite all groups and all my colleagues with whom I'm sharing this presentation to share our experience and to publish some data in the near future. I also would like to show you, this is another accessory pathway that we did a few days ago, and you can see here that this is a septal pathway with 2 insertions. We did this mapping during ventricular pacing, and you can see that you have 1 insertion here and other insertion 1 centimeter from there. You can see that the activation while ventricular pacing is at the same time in both cases. The His is a bit more high. So this tool helps us to identify complex substrates. Sometimes we ablate an accessory pathway and we don't know, but something is happening because the accessory of the tachycardia persists. And now with these tools, we are able to identify that sometimes we have 2 or 3 substrates, and we are able to identify and ablate it successfully. Finally, I would like to thank Dr. NICM for the invitation, and I will be more than happy to answer all your questions. Thanks.
Thank you, Robin. That was excellent and elegant as usual. So you have a couple of questions here. So the first one, what did you find the difference between the HD grid and the Bentray? Is there any difference in terms of what the cases doing with atrial fibrillation?
Well, what I think is that with Bentray, perhaps I have more ventricular extrasystole. Perhaps in a way I have the feeling that it's a bit more arrhythmogenic, but perhaps you and Dr. Ivo, perhaps you can explain your input also. But for me, I think that I have less problems of premature ventricular complex induced by Bentray than with other catheters. Also, with this catheter, we can identify the directionality of the activation. That is not the case with the other catheter. And we saw that with the first case of the accessory pathway, that omnipolar activation and omnipolar technology will help us a lot. But we'll have to do more research to better understand what we have.
In terms of getting inside the vein, because I used the HD grid in 2 accessory pathway cases was a right posterior septal. I found it very difficult just to drive the catheter inside the coronary sinus. So I have to slide the CS, like SL1 sheet inside the CS, then go with the HD grid inside the SL1 sheet. So how did you find it with the pulmonary veins? Do you have any difficulties getting into the vein? Especially we're looking like for the right inferior.
Well, for the right
difficulties?
Yes, that is a very good question. From the right inferior, it depends if the atrium is small or big. If the atrium is small, what I do is I turn it around 160 degrees, and then I pull back the SL1, and in that way, it jumps into the right inferior pulmonary vein. Because to try to put in the right inferior straight away is a bit difficult because the atrium is small. So at that point, you loop it, and then pull back all the long sheet. More than happy to host you here in Belgium and to speak about.
Yeah, we will. I'm looking forward to it. The other thing is, how do you? What about that? What did you learn from the mapping the accessory pathways? So is it the slanting is something really true? Is it? Did you try to do the activation from V side and A side to V side? Is the direction of activation change? Is the ablation side? It doesn't really matter in those pathway.
Yes, but is that, well, I like the accessory pathway because in a way the accessory pathway is the main topic in electrophysiology, I would say. If we are able to identify the accessory pathway with its new technology, we will understand a lot of things. For example, the gap connection in a pulmonary vein isolation. And also what we do in complex cases, also we pace from different settings to see if we are able to see an oblique trajectory. And sometimes we are able to see that, to be honest. Yeah. So we pace from atrium, ventricle, and different place in the ventricle. Last week we have an Epstein disease, and we pace from different places in the ventricle, anterior, posterior, and atrium to see the activation from one side and another, and it helps us a lot. Yeah. It's a good model, I would say.
What about mapping epicardially? Have you tried?
We have tried, yes, with a short agilis is feasible. Yes, the thing is that the impedance is not so good, but well,
yeah,
it's always the same problem. It's not the best model, I would say, epicardial, but sometimes we have no choice and we don't have any other thing to use that or the ablation catheter, of course.
Right. There's a question about the case that you showed that they went surgically. So first, how's the collaboration between you and the surgeon in those cases, and why they let you believe that this case should be done surgically? Why didn't you go from your side rather than just send the patient to the surgery?
The thing is, to be honest, I had the ablation catheter in my hands, and at that point I remember the scanner, and the scanner, the wall is only 1 millimeter, and I know that if I ablate that region, first of all, the aneurysm will stay that, so will not solve the problem. And the second time, I will put this patient at risk if I continue doing an ablation. So the only definitive solution was to eliminate that substrate and that totally this aneurysm. We were discussing with the surgeons because we have to convince there that the origin of the arrhythmia was the apex and the aneurysm. But as soon as we discuss pace mapping, also the activation, the activity before the QRS, they agree that was a good idea to eliminate the aneurysm. And we will do that case both together. I didn't operate, but I was with him helping. Yeah.
All right. So just with my simple experience with this catheter, I think it's very dependent on the technician as well from Abbott team. So because there is a lot of algorithm that you should start building with that, and you have a lot of EGM, they have to be quick interpretation. So I'm not sure if, I think you have a good support in your area. Maybe here our team, they need just to step up in terms of more of a training to use this catheter, because this catheter has a lot of potentials.
Yes.
So did they go for a special training with you guys there in Brussels before you go, or you just deal with one technician who's interested in this technique?
Well, we are lucky in Brussels because we have the European Circle of Training here of Abbott. Well, the technicians also that we have, they are very, very experienced. I have to tell that, well, we have two technicians that are very, very good. Koen Rondelet and Didier, they are very good, and they have a huge experience in the field. So when we have a complex cases, we also try to have the technicians that are really trained. And also I think that Abbott has developed a new training scheme for technicians, and they have different levels. So even if you have a complex procedure, you can ask for a complex expert technician in the field.
Yeah, I think because with the case that I did, I think we get help from your technician, from your center, just to help us doing the setup. But for the local physician here, that we really need to get the good support from the company to provide the help during the procedure. So, and if you want to tell me if you're gonna go to the cath lab and you want to select your catheter, which cases you think that's give me HD grid from the beginning, apart from research, I don't think so everyone is gonna go bumping WBW with the HD grid in the future. This is only for research purposes and better understanding of the WBW. But what about the real cases? What do you think it's useful to use that catheter?
Well, to be
and
honest,
what about the difference between it and the other providers that it's there in the market?
Just to be honest with you, the AFibs ablation that I'm doing with Abbott now, all of them are doing with high density grid. All of them. And regarding accessory pathways, since the last 2 years, all accessory pathways we are doing with high density grid also. Only for research purposes, but all of them are with high density grid.
And cases of atrial tachycardia, atrial flutter, you have any cases showing up?
Atrial flutter, no, but complex left atrial flutter, yes, also. So we have an interest as academic hospital to develop research and to develop this field ahead. So also we have a responsibility to push this field forward.
Sure. I think we can cover all the questions that show up to you, Prof. Ruben. I really appreciate your talk. I really enjoyed it. I learned from it. And hopefully we can now now we have you online. Now next time maybe we'll have you here in Saudi visiting us, and you'll teach us a couple of your track. Thanks. Appreciate your talk. Thank you.
Welcome.
Thank you.
You're welcome.
I think now we're gonna move to the next speaker, Dr. Ivo Roca. He's from Hospital Clinic de Barcelona. The good thing that I'm a Barcelona fan, so I'm happy. So if you can just turn your mic on, please, Dr. Prof. Roca, please. And he will talk about the value of MRI imaging and guiding VT ablation, impact of a new technology. I think this is very important for us as NAB to understand more between EGM and imaging. So the stage is yours if you can start.
Okay, thank you, Dr. Naim, and I would like to first thank the Saudi Arabia Heart Rhythm Society for inviting me and Abbott for sponsoring it. So we will spend the next 20 minutes talking about imaging and high-density mapping for VT ablation. So first of all, I will share with you a VT ablation with the atrial catheter without imaging. So if you have the ability to use this atrial catheter that Professor Casado told you, for instance, in this patient with this infraseptal infarction, you can clearly see that you can produce a voltage map with this catheter very easily. As Professor Casado told you, this is a very safe catheter, and so you can go through the whole ventricle without any problem. And even if with these small signals that you can see here in this D1, D2, D3, D4 in blue, that is point with this red circle, if you increase the gain, you will see these small late potentials that can be tagged with this atrial catheter. So just without using imaging, you can even do the VT activation map, and you can clearly see this figure of 8 VT with these pre-systolic potentials during VT with the atrial catheter. And actually, if you see the video, the sparkling map, you can clearly see the activation of the VT during this figure of 8. And actually, this VT isthmus corresponds with this border zone channel inside this scar. So actually, you can see again the propagation map with this figure of 8 VT in this septal scar. And just by ablating here, you will see that in a few seconds, we will start the ablation, single shot ablation in just a few seconds. We will start just now. And you can see that with 2 seconds of ablation, if you are able to really track the VT isthmus, you can get rid of the VT. So without imaging, you can already do VT ablation with this kind of high density grid catheter. However, my purpose today will be tell you these 3 questions about imaging and VT ablation. First, why? Why do we need imaging techniques for VT ablation? If you see the results of VT ablation in the multicentric trials, it is the Vanish trial, the results of VT ablation are, let me say, far than perfect. You can see here that 30% of the patients in the Vanish trial had VT storm. We were better than amiodarone and mexiletine, but we had a lot of recurrence, more than 50% in Vanish trial. This was in 2016. And what if you look in 2020 in Berlin VT trial? 35% of patients had any VT recurrence. So VT ablation, it's a procedure that must be improved for sure. And what is the key point to do a good procedure? To know the substrate. As this VISTA trial showed us 5 years ago, the more you ablate, the more chance you have to be successful. So you have to ablate not only the clinical VT, but the full substrate-based ablation. So in VT ablation, it's all about substrate. Actually, the Labellas group showed us that despite you achieved non-inducibility, like here, you had a lot of recurrences. So you have to pursue not only non-inducibility, but also the abolition of the full substrate, all late potentials abolition. That's something that we already showed with our SCARD channeling technique, that in the patients that we achieved non-inducibility, but we couldn't achieve the full ablation of the substrate, you had a lot of recurrences. So, but some of you can think, okay, if you have a lot of recurrences, why are we doing VT ablation? Because if you are successful, you are improving the prognosis of the patients. Look at these Kaplan-Meier survival curves. In those patients that you are successful, you have less mortality and less rate of heart transplantation. So VT ablation is a really useful procedure. So we have to really improve our tools to achieve better results. So what is a fail? A fail to me, it's just the first attempt in learning. So what can we learn from recurrences? If you look at this interesting paper that it was published in JCE some years ago, they analyzed the map of the patients who underwent a VT review procedure. And obviously there was a kind of a scar progression in the half of them. But mainly the cause of the recurrence was the same substrate that in the beginning. They had to apply radiofrequency at the same site in more than 70%. So I think that if we have tools to know our substrate before the ablation, we will be able to tailor the ablation for this specific patient. So what can we do in this field with imaging? Actually, the substrate for VT is very old substrate, very well known by Stevenson's group, like 20 years ago. So you have two scars and you have a channel between scars. So very easy concept. And actually, Arenal from Madrid showed us like 9 years ago that by analyzing the intensity ratio of the scar in the MRI, you can reproduce like a 3D reconstruction of the scar. This is the MRI. And you can clearly see this scar here, healthy tissue, and this like channel of intermediate tissue between these scars. It was already shown 9 years ago. Later on, we were working in our group in these fields, and we were able to demonstrate that scar is not only a two-dimensional feature, but a three-dimensional. So you can see clearly here this scar in the inferior part, and you can see scar in the endocardium. 10% means the layer of the tissue more prox to the endo, 25%, so more to the midwall, 50% midmural, 75% and 90% epicardial. So you can analyze by the MRI not only where is the scar, but how is the three-dimensional structure of the scar. And we demonstrated that it was a good correlation, more than 85%, between the MRI map and the electron-anatomical mapping. And just by using MRI, even with this new software that we will be talking about, the other software, you can already know if the substrate is endocardium, like in this A figure, or transmural, like in this example, or midmural in this example, or epicardial in this example. So if you know where is the substrate in advance, you will be able to plan your procedure from the very beginning. Even more, if you have, for instance, this midmural substrate in the outflow tracts, you can decide if this substrate is more close to the right ventricle or to the left ventricle. So you can decide if it's preferable to ablate from the right ventricle or from left ventricle. So there are a lot of things that you can do even nowadays with the MRI with a new software that can make your life easier in terms of VT ablation. If you have the ability to do a 3D MRI, it's even better. And actually, this is the same concept. You can use the MRI to decide if you have to go to the epi or not. So if you use the MRI, like in this Kaplan-Meier, and you follow the MRI to go to the false substrate, then you will have less recurrences. It makes sense. If you abolish the full substrate, you will have better results. And this is even more important in non-ischemic cardiomyopathy, because in ischemic cardiomyopathy, it's mainly an endocardial substrate. But what is a non-ischemic cardiomyopathy? It can be an arrhythmogenic right ventricular dysplasia. It can be a Fallot patient. It can be hypertrophic cardiomyopathy, a Chagas disease, or idiopathic non-ischemic cardiomyopathy. So in this field, it's even more important to have an MRI to see what is the substrate, because it can be everywhere. Even more in the pure idiopathic non-ischemic cardiomyopathy, the pattern of fibrosis can be very different. It can be subendocardial, midwall, or subepicardial, or transmural. It can be diffuse, patchy, whatever. So MRI will help us a lot in this substrate. And actually, why do you have to choose between MRI and high density mapping? So if you combine both, you will have less radiofrequency time, less patients with residual VT, and higher successful in the follow-up. Special scenarios, for instance, this is a patient that we published some years ago that has clearly here in the MRI intramural substrate between both outflow tracts, and we had to ablate from the CASPs and from the RBOT, because we already knew from the MRI that it was fully intramural, so we decided to approach from both sides. Another patients with, again, with intramural substrate, with refractory VTs, and we combined the MRI with this intramural scar in the septum and the CT. And we were, because in these patients we were not able to ablate with the frequency, we realized, like here, that patient had an intramural scar, but the two septal arteries were going to the scar. So we decided to do septal alcoholization based on this MRI and CT scan. And look here how after the alcoholization, patient had no VT. So we tailored our approach depending on the image. And what about in patients with ICDs? We published recently, it's not 2010, it's 2020, like some months ago, that even in patients with ICDs, you can perform MRI with a special wideband sequence, and you can have this kind of MRI maps with the scars, channels, and if you see the electron-anatomical mapping, it's exactly these two channels that were depicted in the MRI that are seen also in the electron-anatomical mapping. And actually, we analyzed this series of patients, and the concordance was pretty much the same than in patients without MRI. But let's move for the more interesting part, I think, especially if some of you are sleepy. I think that now you will wake up with these nice cases, okay? Practical cases, how to do this. Case one, very simple case. Now you're looking at video from the endo to the epi. So in red, scar tissue, in blue, healthy tissue, and in a yellow border zone. Let's move layer by layer. This is 10% layer, so endocardium. Huge scar, but not clear channel, okay? 20% endocardium, small channel here, but not clearly. 30%, so still in the endo, I would say, small channel here, but look here in the epi, in the 90%. So this was an ischemic patient with a huge scar, very dense in the endo, but with the clear channels in the epi. So this patient was an ischemic patient with epicardial substrate. But even more important, what this program, what this software adds, and the MRI can tell you also, is the wall thickness. This is the wall thickness map. In red, wall thickness less than 5 millimeters. And here is the scar. You can see the epi with the channels here, and you can see that this area is a very, not very thick area. So because this was an old patient, and because we knew that this area was very thin, not thick, we decided to start with endocardial approach, despite the substrate was epi, because we combined the MRI scar map and the MRI wall thickness map. And what did we see in the endo? Look at this HG grids voltage map with clear scar and a voltage channel in the middle in the scar. Was pretty much the area where the MRI showed us, with late potentials clearly seen. And this is the VT map. As Professor Casado told you, with the AJ grid, you can map whatever you want with very few time. So we first map the substrate, and we then put the AJ grid in the channel we induced, and you can clearly see this figure of 8 VT and clearly diastolic potentials in this channel. Actually, if you see the video here, you can clearly see this figure of 8. This is a drawing made by our Laia, our technician of Abbott. It always helps, but I think even without the drawing, you can understand this figure of 8 circuit, okay? And if you compare this VT with the MRI, clearly this channel here, it's the channel that VT was using as a VT isthmus. Actually, if you compare the video of the VT with the MRI, I think it's pretty clear that VT was using this MRI isthmus, okay? So case 2, there are some cases when imaging helps a lot. This is another patient with a VT in the anterior wall. You can clearly see this VT, figure of 8 again, clearly a small and large isthmus here, going like this. But if you see the voltage map of this patient, it's nothing understandable. So it's a scar here. VT was going around here, but what was going on here in the substrate? I mean, okay, I will agree with you, but if you ablate here, you will get rid of the VT. But you will be ablating just by activation mapping, but without knowing exactly what is the substrate. So if you analyze the MRI, this was the 40% layer, so intramural substrate. This channel was the channel that was using the VT. So we were looking the endocardial VT that was actually using an intramural channel. So I think that if you feel more comfortable by ablating this VT, because you already know that there is something real, some substrate in the MRI, okay? Another example of intramural substrate. Look at this endocardial bipolar mapping. Nothing at all. But look at the 40% layer of this VT. Clear scar here, some channel here, and some channel here. But nothing in the anatomical mapping. But some late potentials were tagged here. But if you don't have this MRI, you will have these late potentials in the middle of healthy tissue. So what will you do here? So because we knew that in the 50% layer, so very deep in the mid-mural, we had some channels, we could think that these late potentials maybe are the endocardial exit of these channels. And actually, we could map some non-sustained VTs, and in that area, we could find some of these mid-diastolic potentials. But did you feel comfortable just by mapping non-sustained VT alone? I wouldn't say no. Again, we did also the score map, so the pace mapping, as Ruben Casado told you, but also doing a pace mapping. So in white, it's 93% of concordance on the pace map with the AJ grid. And you can see clearly here the exit of this mid-mural channel that is very close with the exit of the VT in the endo. So we used both imaging and AJ grid to really be able to understand what was going on here. And what about the epi? You asked Professor Casado about the epi. We are using routinely AJ grid in the epi. This is the epicardial MRI map. This is the 90% layer of a patient with anterolateral huge myocardial infarction. And you can clearly see in the MRI the scars and clear channels, epicardial channels in this scar. And if you see the EAM map, it means the activation during sinus rhythm. And you can clearly see that there are some late potentials here and some slow conduction here during sinus rhythm in the electroanatomical mapping. And if you see this area, are exactly these areas of the MRI channels. Actually, if you see the activation in sinus rhythm in these areas, you can clearly see that there is a slow conduction during sinus rhythm, so no need for VT in these areas. and you feel comfortable because you see this slow activation that is in an area of the MRI showed you that there are channels. More, we could map fast VT here with diastolic potentials, and this area was the area that MRI suggested you. Another epicardial case, actually this is a very recent case. This case was done yesterday by me. This is a patient with a very early left ventricle dysplasia. And if you can see here clearly, two small scars in the epi interlateral wall. And you can also see that we used also the CT scan. So you can see the coronary arteries here merged with the MRI. So first, from the very beginning, we were able to know that we could ablate here without damaging the coronary arteries, because you use both techniques, CT scan and MRI, merged together, and there is no coronary artery here. Actually, in the MRI, in the electron anatomical mapping, you can see these two small scars that are these scars in the MRI. And if you see the late potentials map again, this late potentials area was related with this area between two scars. So I have more cases that I can share with you if there is enough time, but at least to conclude, I would say that VT ablation, it's a complex procedure with a limited long-term efficacy. So knowledge of the three-dimensional substrate plays a key role for more successful procedures. Imaging techniques are very useful in this field because they increase our knowledge of this specific substrate for this specific patient. So you can plan different approach for this specific patient. This is also helpful, as I demonstrated you, in ICD patients. And it's true that it's not demonstrated in randomized trials, but I think it makes sense. I mean, it's better to use Google Maps to go for a place that you don't know. So it's better to use imaging to ablate substrate that you don't know. And I think the best combination for VT ablation, it's imaging, so anatomic substrate, functional substrate with high density omnipolar mapping. And by using these techniques, you can tailor your ablation technique for this specific patient. Thank you very much. I would like to thank for the audience. I'm open for discussion, and if you need to know more cases, I have plenty of cases, backup cases. Thank you very much.
I really appreciate it, Dr. Rocca. It's very unique. It's very interested talk. So I think for the time wise, we can have time for one or two cases. If you have like two cases that you can build them up for us, I think okay. People are excited to hear to see those cases.
Okay, so are you looking at my screen again?
Yeah, it's okay. Back again. So I can give you a room for two cases as well.
Okay, so I will show at least one case that I call the perfect case. Okay. This is a patient with ischemic heart disease that went to our lab for a VT storm, and we decided to do a VT ablation. So as our approach is always the same. First, we do substrate mapping. I will show the MRI at the end, okay? So it's the surprise. And you can clearly see two areas of late potentials in this lateral wall. You can clearly see the late potentials here. This is also a message that when you are using AGIC catheter, you have to increase our recording system amplitude. One of our colleagues in Spain called, well, you will know it, Professor Moreno, always say that you have to increase our recording system amplitude until you get noise. If you don't have noise, you don't have increased enough, okay? So, because with AGIC catheter, you can also see some small signals that are always interesting. This is the voltage map, so clear scar here, very heterogeneous scar with some channel going like this, going like this, going like this. And actually, this late potentials area, these three late potentials area were corresponding with these potential three channels. Actually, we were able to map the VT. And you could clearly see again that this is a very important thing that HGrid gives you, that that at least today any other catheter gives you, that this the directionality of the VT. So when you are using the HGrid, you have not only to look at the colors of the map, but also about the direction of the VT. So you can clearly see that there are diastolic potentials in these D channels. D channels is here. So if you have diastolic potentials here and nothing here, you can move your catheter like this to go more deep into the VT isthmus. So thanks of the directionality of the HGrid, you can decide if you have to move to the lateral part, or you have to advance or to pull back your catheter. And also the fact of the omnipolar mapping, as Ruben Casado told you. Look at this signal in C2, C2, C1, that C2, C1 is this direction. There is almost nothing. But thanks of the omnipolar mapping of the HGrid, C2D2, that is this one, this one, that cannot be seen with any other catheter. You can clearly see this diastolic potential. So thanks of using both directions with this catheter, you will always be able to track any isthmus of any arrhythmia. I can tell you, I've performed like more than 40 cases with VT with the HGrid, and almost everyone, in every case, you can track the VT. Then you can be not successful because you cannot ablate it, but at least you can see where is the problem. The activation map, again, it's going like this and like this. It's using this isthmus of the voltage map. This is the propagation map again, figure of 8 again. I think figure of 8 is one of the most common patterns of VT in structural related VT. Maybe in the past we didn't see it very often, but I think it's because I have high density that you are really able to track the full circuit, okay? But look at the MRI. This is the 3 Tesla MRI. Exactly the same channel that in the electroanatomical mapping. So with this MRI, you really are able from the very beginning to know that you are dealing with complex substrate in a complex patient. And you are dealing with a very long channel, not so easy to ablate because maybe you have to ablate here, 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 so in many places. If you see the isthmus of the VT is exactly using this VT channel in the MRI. So MRI shows you from the very beginning the potential isthmus of the VT. So I think this is the perfect case because the MRI is nice. You have the full circuit of the VT mapped using this MRI channel, and you have the late potentials channels also. So I think I will end with this case for the matter of time, and I will be open for any questions.
Excellent, Dr. Roca. It's a very unique and excellent presentation. So let's go with a couple of questions. We have a question all the way from Kenya, from Africa. So they are asking about the software. Is this special software that you have? Is it for clinical use or still for research purposes?
No, it's called other software, and it has already the FDA approval for US and the CA mark for Europe. So we are using it routinely for VT ablation, for AFib ablation. Actually, we are running also live cases with Abbott cases also, even in the webinars to know how to use it. So you can use it routinely.
All right, and the routine 1.5 Tesla can give enough raw data for this?
Yeah,
image?
I mean, it's like having a a nice Porsche car or a normal car, but with 1.5 Teslas, you can have nice images. Actually, all the images that I showed you for the ICD patients are done by 1.5 Tesla. So if you have 3 Tesla, it's better. But the key point is not only the resolution of the scan, but the slices. I mean, you have to do thin slices. So like less than 5 millimeters slices. Otherwise, MRI will not have enough resolution and you will be like inventing things.
Right. Another question, I think you covered some of it. They say, how's the good MRI imaging with the patient with the ICD? Is the lead location change the quality of image? Do you have any better understanding of quality of image with the patient with the ICD?
Yeah, well, actually, quality, it's with a normal MRI, it can be a problem, especially for the anterior wall and the left and the lateral wall of the left ventricle, not because of the lead, but also because of the CAN, of the ICD CAN. So we are using a wideband sequence that it's already available, and this wideband sequence is using a different frequency scan. I cannot tell you very details because I'm EP, not engineer. But by using this wideband sequence, you can avoid more than 90% of the artifacts. So you can have a really nice images. Actually, I think half of the cases that you have seen today are wideband sequences.
Right. And do you use CT, MRI for all the cases pre-lab almost?
No, we are using MRI for every patient, and we are using CT in case of epi, in the epicardial ablations, because then we are using the CT to merge the coronary arteries to be able to do the procedure without doing a cardiac catheterization during the EP procedures that you can always do, but it's like a mess to do a cardiac catheterization and then check in the fluoro. So if you have the CT scan, then you can merge together and be safe. Otherwise, we're not doing CT because it's expensive to do two tests, and also it's radiation for the patient.
Right. So basically, for the you do the MRI first, and then if you expect it, it's epicardial, then you do the CT later on, huh?
That's it. That's it.
Right. And for the patient who came with the VT storm, so sometimes you don't have the pleasure of doing imaging before your case, and you have to rush the patient to the cath lab. Do you have any difference in terms of your outcome, your center outcome, if you have the pleasure of doing the imaging at the beginning, or you rush your patient right away? Do you see really it is really that big difference?
Well, I think it's
comparing just a local experience.
Yeah, I think, well, some years ago we published that with MRI we had better results. But if you analyze the patients in which you don't have the MRI, these are worse patients. Maybe you are doing not the MRI because they are in VT storm, and when patient in a VT storm, you will have worse results for sure. Or they are patients with chronic kidney disease, and chronic kidney disease itself, it's a prognostic factor of recurrence. So I think that MRI is not a matter of just improving our outcomes. You can improve our outcomes with MRI, but you will not make a huge step forward by using MRI if you are using a grid or any high density mapping catheter. It's a matter that you will be more able to tailor your approach for this specific patient, and in sometimes you will be able to understand what is going on during the procedure for this patient because you have the MRI. Otherwise, you can be the typical patient that you have not a very understandable anatomical map, no VT inducibility, so where to ablate. So if you have the MRI, you will be able to at least know what to do.
All right, really thanks. I think with this we cover all the question. I'm not sure if that Prof. Robin, you have any question to share, or Dr. Roca, if you have any question for the first presentation that's given by Dr. Robin.
No, I think it's just very interesting what Ruben told us about the directionality in accessory pathways. I think AG-GRID will help us not only to be more successful, that I think we are successful properly in accessory pathways, but to understand EP itself, to understand a lot of things that we thought we knew, and maybe we didn't know so well. So I think it's also nice
to better understand the substrate, to extrapolate to complex cases. Very nice that you are showing today, Dr. Roca.
Right. So I think we will come with come to the conclusion. It was very nice talks. To both of them were excellent. I learned myself, and hopefully that will give us some idea to our local physician here in Saudi and the Gulf. And you see that we have 1,400 attendees so far in this presentation. It was very good, and I keep getting a lot of WhatsApp messages. They are saying that there are a lot of they are very happy with the presentation. Hopefully we'll see you in face-to-face after this Corona time. And we are pleasure to invite you here in Saudi just to come and share your experience. And we will see you around. Thanks for accepting the invitation, and thanks for Abbott for organizing the presentation, and Kunuz Ritaj and the Saudi Heart Association as well for the usual support. I really appreciate it. And hopefully Barcelona will win the league this year as well.
Hopefully. Thank you very much.
All right. See you guys. Thank you. Appreciate it. Bye-bye.